Welcome everyone to our training today on California's Health Homes program with Chris Flannery. Chris and I have been running into each other at dental committee meetings and California Health and Wellness meetings and various places around the community for the last couple of years. And this is an unusual program that really applies to a few people, but for those people, it could be super, super important. So we want to make sure to get the word out. And we thank Chris for taking the time to come to our meeting and share this information. We are recording it and we will be making it available on YouTube and sharing out the link. So if anyone has missed it or you want to share it with staff at your program, I think staff at the Regional Center would benefit from knowing about this and other places. So we're glad that we can offer this and record it and make it available afterwards. So without further ado, I'll turn it over to Chris and let you introduce yourself. Thank you so much, Chris.
Hello, everyone. My name is Chris Flannery. Thank you, Sonia, for having me. I really appreciate being able to bring this program to everybody. There's a lot of information here, so I just want to preface that, if there's ever any questions or you need clarity on anything, please don't hesitate to ask. I think I'll rely a little bit on Sonia to field whether or not there's chats in the box or if somebody's raised their hand, etc. But yeah, so we're going to talk today about the Health Homes program. This is a Medi-Cal initiative, for folks with certain chronic medical conditions. One of the things that I like to talk about with this program is that there are a whole bunch of people out there, and a lot of them have issues that need extra help. And this is one of those programs that, man, I wish I knew about when I was a firefighter and a paramedic. When I would respond to folks on the street, if I had this program in my back pocket, I could say, oh, hey, check out this Health Homes program because this could help you. So there are quite a few services that this program provides, and it's for folks with chronic conditions who need extra help. And we'll go over all of those coming up. So a couple of topics that we're going to cover today. We're going to go over the general overview of what the Health Homes program entails and talk about these things called community-based care management entities, or CBCMEs. You'll hear me say that acronym a lot. However, if there's an acronym that I say, or I'll try not to use acronyms in general, but if there's something that I'll say and you don't understand what it is, please don't hesitate to ask for clarification. I'll tell you all about it. So CBCMEs, or community-based care management entities, these are basically the providers in the program, and then the managed care plan and how they work together and their roles together. Also, we'll be talking about the different people who make up the care team, the Health Homes program care team, and there are quite a few. We'll talk about the eligibility and enrollment. We'll talk about the 6 core services and what that provides for folks. And we'll also go over a little bit of how information is exchanged, throughout the different entities that work within the Health Homes program. And if there's extra information that won't be covered fully on this program, on this training here. However, we have a whole bunch of resources for you to delve into and read. So we'll go through each of these, and again, please ask questions if you have them. Okay. All right. Let's go ahead and get going. So the Health Homes program, what is it? So this is a new Medi-Cal initiative. And what it does is it gives folks who have certain chronic health and or mental health conditions and who have high care needs, so people who have high acuity or complexity in their in the course of their medical issues. And it gives them a care team, and specifically a care coordinator. And this care coordinator, I like to say, is the MVP. They really are a very valuable member of the care team. They are the main liaison, you could say, or the main person to interact between the patient or the member and the provider, and the provider meaning all of the people that work with the patient or the member to propel them forward in their healthcare. And so this care coordinator is the mainstay of this program, and what and who, I should say, works with the member most often. So this program, members will stay enrolled in their Medi-Cal managed care plan, and what they do is they get this extra layer of support, as you can see in bold there in that first paragraph. This is at no cost to folks who have Medi-Cal. This is part of their benefits. So this is something important to know. A lot of people say, oh, well, you get all these things. How much is this going to cost me? It's not. If you're a Medi-Cal member, it becomes a part of your benefits, and it is at no cost to you. And your services do not change as a result of enrolling in this program. And these CBCMEs, these community-based care management entities, they're going to be primarily responsible for actually delivering these services. And these services we'll talk about in a few minutes. All right, so let's talk about the CBCMEs, or the community-based care management entities, and the managed care plans and what their roles are. So the CBCMEs, or community-based care management entities, they have the responsibility, and in coordination with the managed care plan, for ensuring that health homes programs, health homes program members receive their services. And in most cases, this is just going to be their primary care provider or physician. So the CBCME will be assigned to the member as they qualify for the program. More than likely, if they already had a primary care provider assigned to them, when they signed up for Medi-Cal, then that PCP will most likely be their CBCME for this program. And that's not to say that that's the only CBCME that member may have. If they have a very complex issue, there may be multiple CBCMEs around that work with the member. Here are a few examples, and by no means is this list comprehensive. There are, you see that last bullet point on the right side, other organizations. This program was designed to be as inclusive as possible, to utilize as many different services and other providers that, could help members as possible. So you'll see, just a primary care physician, your primary care physician group, FQHCs, or federally qualified health centers, are part of this, substance use disorder treatment providers, and more. And so just a short list to, kind of get you a good idea as to who would be a CBCME in this program. All right, we're going to move on to who the care team is. So the core care team. The first one, remember I was talking about the care coordinator being that MVP. This is the main person who interacts with the members and all of the different care team members that are present on the care team. The care coordinator will oversee those services and implement what's called a health action plan, or HAP, H-A-P. And a health action plan we'll talk about in a minute, but it is a head-to-toe assessment of everything that's going on with the member. A head-to-toe assessment for everything, including physical, medical conditions, mental health conditions, socioeconomic conditions. Basically, trying to enumerate every issue that needs mitigation within the parameters of the patient's healthcare, and then implementing a plan to do that to help them. And so that's the health action plan in a nutshell, and we'll talk a little bit more in detail in a second. And the care coordinator, in addition to implementing the health action plan, they actually work with the community. They actively seek out different community-based organizations that may help the member propel them forward in their healthcare, and this includes arranging transportation, ensuring that they're getting to their follow-up appointments, and working with pharmacists to get their medications, and if they needed to even if they needed to get to an appointment or to get to the pharmacy to actually pick up their meds, they can arrange for that transportation to make sure that they actually get there. And then the follow-up is very important. But they directly support the members' self-management. In fact, they help teach them about their issues and how to properly treat themselves to ensure that they get better. The second member of the core team will be that Health Homes Program Director. They're in charge of overseeing the management operations of the team. They make sure that reporting measures are compliant and that they they convey those quality measures, like whether or not somebody's actually improving as a result of utilizing the program, and how many people have enrolled, how many people are, we're working towards getting people under a safe roof, if they're folks experiencing chronic homelessness, and more. So the Health Homes Program Director actually oversees the overall operation of that particular care team. And then we have our clinical consultants, and these are going to be folks that, maybe they're specialists, physician specialists, oncologists or cardiologists, et cetera. Or they could be other clinical folks that specialize in a particular area. And they can, they're utilized as a kind of review and advisor to the health action plan and the rest of the care team. So if somebody needed extra information, they weren't an expert on cardiology, they can talk to a cardiologist, and that cardiologist could come on as a clinical consultant. And then they would be able to work with the member to ensure that they're getting the proper care. A few additional care team members that we see here, pharmacists, nutritionists, and other specialists, CHWs for community health workers, and the housing navigators for folks experiencing chronic homelessness. It's a really big one. A lot of people are really excited about that one. It's a dedicated paraprofessional that, dots all the I's and crosses all the T's, and, worries about the bureaucracy while the member can worry about getting themselves better. Really, really valuable member. And even family members, friends, and or caregivers can be a part of the care team. So this is I think pretty cool that, we have family members and friends that, they see us day in and day out. And, really, nobody knows anyone better than themselves, but I would say the next best thing is somebody who lives in the same house or works with them day in and day out. They understand them a little bit more. And so they can actually be part of the care team in order to get better insight into what issues are going on. And this, of course, this is all contingent upon the member wanting that or not. So if a member didn't want their family members as a care team member, they could say that, and then, of course, we have the right to refuse service, right? But the family members can actually be part of it, and they can accompany them to appointments, and they're really valuable. And then working with the CBOs, the community-based organizations that are already within the community, some providing services already that the member may utilize already, or if they haven't been connected with those CBOs, like I said, the care coordinator and the rest of the care team will actually identify those community members, those community-based organizations, and they will get them connected with the member so that the member can take advantage of those services. So it's a pretty cool program in that, this is baked into this is required of the care team for them to, actively look out in the community and make sure that the member is getting everything that they need. All right. Threw a lot of information at you. If there are any questions, please, again, stop me and let me know. But we're going to move on to the eligibility and enrollment. There are a grand total of 3 requirements to enroll in, or to be eligible for the Health Homes program. Number 1 being enrolled in a Medi-Cal managed care health plan. So, we there are a whole bunch of health plans up and down the state. Some of them that serve Medi-Cal members and some that don't. So it's really important to differentiate and distinguish that the first requirement for this program. So if you're looking to enroll, you have to be enrolled in a Medi-Cal managed care health plan. And if you're a fee-for-service member, fee-for-service delivery system may be a little bit more simple. You just pay for the service as it comes, But unfortunately, folks who are FFS or fee-for-service members do not meet eligibility criteria based on the fact that they're not enrolled in a health plan. So one, health plan. Let's go to the second one. So there's quite a few things within this the second eligibility requirement. So that we have certain chronic conditions that were identified by a team of specialists and policy folk that we're looking at the top 3 to 5% of utilizers for Medi-Cal, and typically those folks are quite ill. They're in the hospital a lot. We're seeing them in the emergency department a lot. And the ICD-10 codes, which are codes that are, they're assigned to different ailments. And even has enough specificity to talk about the left arm versus the right arm. Let's say you broke your arm or something like that. You'd have an ICD-10 code that would identify that you had a fracture in the arm and which bone and et cetera. But we have these chronic conditions here that you see on the screen that are representative of the top 3 to 5%. And if you see that first box right there, at least 2 of the following: chronic obstructive pulmonary disease or COPD, diabetes, traumatic brain injury, chronic or congestive heart failure, CAD or coronary artery disease, chronic liver disease, chronic kidney disease, dementia, or even substance use disorders. So if somebody were to have 2 of those issues right there, those ICD-10 codes in their file, then they would check this box, and then we could move on to the next eligibility criteria.
Chris, may I interrupt with a quick question that's shown up in the chat? Just
certainly.
Are you willing to share out the PowerPoint so people don't have to be taking notes?
Oh yeah, absolutely, of course.
Okay.
Yeah,
we can share it out afterwards.
Sure, absolutely. Mm-hmm. I actually sent you another PDF of the slide deck, and please feel free to share that with the group.
Thank you.
Of course. Yeah, there's a lot of information here. I totally understand if you want to just have the slides so you don't have to take notes. There's quite a lot of information. So going back to that first bullet point, that first box. So if you had those 2 of those issues, we could check it and move on to our next criteria. But let's say that you only had 1 of those, but you had hypertension, if you had high blood pressure, and then some of the more cardiovascular and respiratory-based diseases, that would qualify you. And then if you had what we call the SMI population, the severely mentally ill, there's different psychotic disorders such as schizophrenia, bipolar disorder, major depression disorder. These are those that qualify folks through the SMI component. And the reason why I was separated from the rest of the physical chronic conditions, there was actually a decision made to kind of stagger the admissions so that, with the physical conditions, there's so many people that have those physical conditions. They wanted to kind of get the program up and running for 6 months, working with the SUD, the substance use disorder folks, and folks with physical chronic conditions. And then 6 months after that, the implementation started with the SMI population. That's that bullet point. And then the last criterion we see here is asthma, just by itself. It's lonely self right there. With asthma, we have, so I mentioned that I had been a paramedic. I would say that like 90% of the calls that I was that I was called to that had to do with some sort of respiratory distress was asthma. And I guess asthma was isolated as a single criterion for eligibility for this program simply because it's so dangerous. You absorb that little protein, however you breathe it in, you eat something or what have you, and then suddenly your bronchioles are seizing up and you're going horizontal, and then somebody like me is going in and intubating, which is unpleasant. But there you have it. You have asthma as a single criterion there.
Chris,
So
we have
to
a
review, we
couple
have,
questions
okay, absolutely, certainly.
on specific conditions. So one was with respect to traumatic brain injury and dementia. Would this include people with intellectual disabilities who suffered brain injury at birth? And then the second question is, what about anxiety?
Right, so anxiety, I'm not sure if that is a specific ICD-10 that's been isolated for this program. I'm sorry, I don't know. I know that there are 1,626 ICD-10 codes that qualify people for this. I can look into that and get back to you. And I'll certainly try to do that as soon as possible. For traumatic brain injury, so if this was something that happened as a result of, during birth, if they have TBI, if they have some sort of traumatic brain injury, then that would qualify them. So if they had that specific ICD-10 on their record that that indicated traumatic brain injury, then they should qualify. At least one of those. That first box, so they'd have to have something else on top of it, more than likely. This is all at the discretion of the managed care plan. These are the issues that are most likely to be the high utilizers. So you'd have to talk to the managed care plan that you are enrolled with to really get a definitive answer as to whether or not that individual would be eligible. But my guess is yes, but then again, I don't want to guess, I don't want to assume. I want to make sure that you get the proper information. But if they have TBI on their record, if they have traumatic brain injury, then that should be an eligibility, that should be a positive eligibility. Right. All right, so reviewing, we have the managed care plan enrollment. So you have to be a Medi-Cal managed care plan enrollee. You have to satisfy one of these 4 boxes that you see on the screen right now. And then we can go on to the next eligibility criteria. We have our acuity/complexity criteria. So if folks have 3 or more of those conditions that we mentioned in the previous slide, then that automatically will satisfy the acuity, and then we're off to the races getting them set up. And then let's say that they stayed an inpatient stay in the hospital in the last year. That would also qualify them for acuity and complexity. If they've been in the emergency department 3 or more times in the last year, that'll also qualify them. And then if they are experiencing chronic homelessness, that will also put them in the acuity criteria positive box. Here's a definition of chronic homelessness. If they have 12 consecutive months or more, if they have 4 or more periods of time in the last 3 years that they've been in conditions such as that would qualify them as chronically homeless. A person who lives in transitional housing, for example, or has been residing in permanent supportive housing for less than 2 years is considered chronically homeless if they were chronically homeless prior to that residence. So there are AB 361 for the state legislature put out, and then with HUD at the federal level defines this as what you see. All right, we have an example of a potential health homes program member. We have Jose here. So I'm going to go ahead and read this aloud, and I'm going to encourage some participation here if people want to say anything. Here we have Jose, who has asthma and has visited the emergency department 6 times in the last year for uncontrolled asthma. Despite referrals to an outpatient clinic to help get his asthma under control, Jose has not been able to get that follow-up care. So can anybody tell me, like based on the few slides that we just went over, what do you think may qualify Jose for the health homes program? Let's assume that he is already a Medi-Cal managed care plan enrollee.
Diagnosis of asthma.
All right, so we have asthma here, and if you remember, it was that fourth box at the bottom that was just by itself. So that would automatically take care of the chronic condition. So very, very good job. Is there anything else that kind of pops out at you?
Multiple hospitalizations?
Yeah, so we have, so he's been in the emergency department 6 times in the last year. And if you remember, it said 3 or more times in the acuity criteria. So this is 200% of what we're looking for. So this is a really good candidate, especially since they need to get help, you know, getting his asthma under control, you know, even with referrals to get care done and still things aren't happening. Yeah, he needs a care coordinator. He needs somebody to advocate for him. Great, good job. All right, so we've talked about the eligibility criteria, again, managed care plan enrollee, chronic condition criteria, and acuity criteria. But we have now our enrollment. There are 3 ways for members to enroll, and the first one's going to be the most prevalent. There's a little bit of backstory to this one. So the first one, many members who may qualify will be contacted about the program. Now, it's a vague sentence, yes. But what it means, so the DHCS, the Department of Healthcare Services, will issue a targeted engagement list, or what we call the TEL, the TEL. And that's issued every 6 months, and that it's issued to the managed care plans. And what's on that list is a rundown of all the different members that had all those ICD-10 codes that we were talking about so much about a couple slides ago, that pertain to this program. And they send that out to the managed care plans who have their own lists and maintain their own lists about this stuff. They'll compare and contrast, and they'll make sure that any member that they have on the TEL is contacted about this program by snail mail or however the member had elected to be contacted by. Text message, email, things like that. So they'll send out a letter and say, oh, hey, Chris, you know, it looks like you may qualify for this program. Here are a few of the high-level things that it does for you. We invite you to call us and we'll get you started if you're interested. That's the first and most prevalent way. The second will be, oh, hey, well, you just went to your primary care physician, or you went to a clinic and somebody recognized in you, you know, the conditions that may qualify you for the program. Well, then they can refer folks the same way they would with any other Medi-Cal service. And you refer members to the managed care plan and they can get them started. And then the third one is back in the old days when we could walk down the street and not have to worry so much. I would walk, you know, around with my little hand truck with all the materials that are all in my bookcase that you can't see right here, just waiting, collecting dust. But I would have a whole bunch of paper materials that I would give out to different meetings and committees and just drop off at clinics just to make sure that everybody had the information. Well, you know, like if I'm walking down the street and somebody sees that and like, hey, what's that? You know, then I tell them, oh, hey, well, there's this program. And that would, you know, is probably the least prevalent. I have a story. I was walking in San Francisco and a man stopped me and started berating me. And, you know, I could tell that he needed a little bit of help. He was, you know, definitely could have been chronically homeless. And so using my paramedic training, they'd say, okay, bring your voice down and calm and you know, try to calm people to listen to you. And so I handed him a member toolkit and said, hey, this program might help you. You know, this is what I do. He thought I was a finance guy or something, and was upset with me for some reason. But it de-escalated the situation. I didn't get punched in the face and I got information to him. So it was a win-win. So yeah, that would be the least prevalent way that people can enroll is by self-referral. But these are the 3 ways that you can, and I'll give you some information at the end of the presentation, you know, so that you like actual information to reach out and contact managed care plans for this. Right, so are there any questions? We just went through a lot of stuff. Make
yes,
sure.
I have a question.
Yes.
My daughter is what you call a Medi-Medi.
Yeah.
She has multiple diagnoses. Some of them
Mhm.
are developmental and some of them are mental health.
Mhm.
Now, she doesn't go into the hospital when she's having a crisis. But she will call her psychiatric nurse. She will call her case manager, who's also her therapist, when she's upset, several times a week.
Mhm.
So would that qualify her? She is in, like I say, she's a Medicare and Medi-Cal. Would that qualify her? She has a case manager who does some of this. She's also in Kaiser's special needs program. So she's already getting a lot of support. Is this this program in addition to that, or is this something that she may be already in and we're just not aware of it, or what?
So I don't think that the last part of your question, that she may be a part of it and you don't know it, I would think would be very unlikely, because you certainly would be most likely on the care team with the rest of the folks helping. So far as whether or not she may qualify, she may very well. It would be worth it to contact. And so as Kaiser, some Kaisers don't service Medi-Cal, but if she's Medi-Cal, Medi-Medi, as you had mentioned, you know, people who are dual eligibles or Medi-Medi still qualify for the program for sure. There may be other things that are better for them just by virtue of how Medi-Cal and Medicare kind of, they're siloed programs. There's no informational exchange between the two, and there's different billing regimens for both of them, and 80% to 20%, et cetera. And so there may be a couple hoops that some of the back office staff would have to jump through to get the information for things, but once that's established, it should be fine. And that would not disqualify anybody from being a Medi-Medi, would not disqualify anybody from enrolling in this program. Now, if she has some of those chronic conditions that we had mentioned earlier, you had mentioned that she has multiple issues, but if those conditions, if it satisfies those chronic conditions and she's got the acuity criteria as well, then it really doesn't matter what else is going on. The qualification has been satisfied, and then it becomes a benefit, and a benefit that somebody can choose to access or not. So I would say the best bet for you, Joyce, would be to talk with the managed care plan that she is a member of, and see if she qualifies, and talk to somebody at that level, because that will be the definitive yes or no. I lean towards yes, just by what I heard, but of course it really takes the granular detail that the managed care plan is going to go through, and looking at her record and looking at her acuity and how many times she's gone to the hospital, how many times, or how many chronic issues or conditions she has, etc. So yeah, my advice would be to talk to the managed care plan that she's a member of, and go from there. I can get some information for you. At the end of this, you'll see I'll have my email and whatnot. You can certainly email me, and we can work it out together, or I can get you in contact with the appropriate managed care plan for your area.
Okay, thank you very much.
You're welcome.
You've been very helpful.
Donnell and Brenna both had questions. Do either of you want to ask your question?
Sure. Hi, yes, I had a question in regards to a family member of mine, because I presume my mom would have had a say in this, but I'm the eldest now. So I have a brother that was in the system, and he was released from a probation officer, didn't know what to do with him, so they just placed him in a hotel. And I said, that's not adequate for him if you know he requires medication, which they didn't even release him with his medication, so he got in an altercation. He's schizophrenic, but yes, take lithium. But I was saying that there's systems, there's programs like I know you mentioned the halfway house that he could have been placed in had the people, you know, did their due diligence. And so currently he's in a, he was placed in a, like a Tascadero, and then he was released and sent elsewhere. But they're not helping him to be like, you can tell he wants to be involved in his own care, but he doesn't have the capacity to be self-directed. So he kind of has to be guided regularly. And then he's, like I said, he's got schizophrenia. How could he access this type of program with he has a conservator? They wouldn't let me become his conservator. So how would he access this program if I feel that this would be a very positive thing for him to have access to, as opposed to what the county up north is tending to do. And I believe he is with Medi-Cal, because he's also they're also paying for his placement through his Social Security that he receives.
Yeah, so reentry folks, you know, that sometimes it can be really difficult on the reentry participant, and you know, just listening to what you said, that he has schizophrenia, that's one of the SMI qualification criteria. If he is a member of the managed care plan in his area that services Medi-Cal and having schizophrenia and maybe classified as chronically homeless, if it's deemed appropriate, but that would have to be done by the managed care plan itself. So again, my advice would be to contact the managed care plan on his behalf. You said that he has a conservator,
Right.
and that and they're unwilling to. Have you discussed any kind of seeing that he needs extra help, have you discussed with them being able to get him signed up for something such as this, or has it just been kind of crickets on their end?
It's crickets on their end, but I've asked about other programs to where I was like a special day program, because that's all that I'm familiar with. And they didn't seem conducive to going in that direction. So I don't have a lot of say, and I asked how could I be a conservator, and I don't have the energy or the time, because I have a severe special needs child with cerebral palsy that takes a lot of my time, plus 2 adolescent boys. So finding adequate resources for him is not, although I would like it to be on my priority, I can't manage all of it. I need a team. Other people have a team for a reason to address these individuals. And so I feel that this program, this CBCME's, would benefit him. Like I saw on, in Sacramento County that they have the homeless thing. He would be homeless because he has no understanding of paying for daily needs or rent or energy or things like that. So he would technically, he says he'd rather be homeless than live where he's at right now, due to what he's being exposed to for the individuals that are physically creating the contact.
Yeah.
He has to just take it.
What county does he live in?
It's in Crescent City, so he's in the facility in Eureka. So
Eureka.
it's Humboldt County.
Humboldt County. I have unfortunate news for you. Humboldt County is not servicing Health Homes program patients. So.
And I asked them to move him to not California, but to Sacramento County. And when they released him from where he was at, and they sent him all the way to Tascadero down there, they wouldn't release him here, close to a family member. He has no family up there. So we're Native Americans, so that doesn't help, sure.
I would say talk to his conservator, because that person would have the capability of doing this, get him moved down to Sacramento if you can. And if he is a member of a Sacramento managed care plan, he has schizophrenia, and he can be classified as chronically homeless or has additional issues that may qualify him for the complexity and acuity, then he would qualify and it would become a benefit and he would be able to take advantage of it. So I would, man, that's a difficult situation. I'm very sorry, but I would talk to the conservator and really kind of demand, hey, he's not next to us as family. We need him closer to us. And two, he needs extra services, and this is something that he could take advantage of in a different county. That's the best I could do for you. I really feel for you. I'll think about it and get back to Sonia and see if there's anything that I can do beyond what I know right now. Do a little research for you. Yeah, unfortunately, Humboldt County. You know, it was an elective thing, so certain counties didn't elect to do this, and we'll talk about the counties that did and that are going live with this. But I wish that it was just simple and I could just say, oh yeah, just talk to the managed care plan up there. But yeah, I'll think about it for sure, and I'll see what I can do for you. Okay.
Thank you. I'd appreciate that. Thank you, Chris.
Okay, no problem.
Thank you for the valuable information you're offering today.
For sure. Just going to write down a few notes just to make sure that I get everything right.
While you're pausing, I'm going to go ahead and launch a poll, and then we'll continue on. We've got 13 more minutes, but I'm going to launch this poll right now and read the questions for you. So the first is, did you learn something? And obviously we're not done with the presentation yet, but did you learn something about the Health Homes program? Yes or no? And the second question is, are you satisfied with this activity? Yes or no?
Ooh, I'm getting my report card halfway through. It's gonna be great.
There you go. You better be more than halfway because we got 12 minutes left.
Oh yeah. Okay. Well, I'll speed up a lot then. Okay.
Okay. We'll just give one more second. We've got 14,
all the questions.
I know, 14 people. No, the questions have been good, and I think it's been really helpful.
Absolutely.
Okay, I think it's evened out on answers. I'm going to end the polling and share the results, and just bear with me 1 second. Okay, go ahead and continue, Chris. I'm just going to take a snapshot of this.
Sure. All right, I got an A+. Okay. Well, I'll move on quickly. This slide talks about all the different fee-for-service beneficiaries that are in these 10 counties. They were sent a letter urging them to join a Medi-Cal managed care plan so that they could start utilizing Health Homes program. You know, some of the things that are worth mentioning when you're engaging folks about this is that they get this care team. They get to keep their doctors. You know, I knew a doc that, you know, would harbor friendships with his patients 30 years strong. And, you know, there are other programs that, you know, that you would be just randomly assigned to somebody. But in this program, they made sure they baked it into the program that you get to keep your doctors. These are extra services. So your services don't change as a result of enrollment. They don't, there's just added benefits on top. And it's at no cost as part of your Medi-Cal benefits. So here's a few programs that work well with the Health Homes program. Seeing as we're in California, we have quite a few programs that address multitudes of different issues. But as you can see here, I had mentioned the Medi-Medi population, the people who are dual eligible. They do qualify, but there are other choices that may be a little bit better for them. And I'll actually show you one of those in the next slide. But here you can see LTSS, or long-term services and supports, work well. CBAS, or community-based adult services, in-home supportive services, work well with this. So it is you know, pretty inclusive. The next one, Cal MediConnect, is what I was going to mention. That's like kind of a dual eligible health plan type organization. That might actually be better for folks with Medi-Medi, but if the Health Homes program is something that people want to get a part of, they wouldn't be able to utilize both. So you'd have to choose between the two. People who are in skilled nursing facilities, SNFs, for a duration longer than a month plus another month. If they're discharged before those first 2 months elapse, then they should still be able to enjoy benefits. But it's after, then they would have to reapply. And then hospice, folks who are at end of life, a lot of the services that Health Homes program provides is superfluous to their needs. All right, so I've got 9 minutes, so I'm going to go really quick through these 6 core services. I usually talk about each quite a lot, but I was speaking too much. I was too verbose, as they say. So we have comprehensive care management as the first core service, care coordination, health promotion, comprehensive transitional care, member and family supports, and referrals to community and social services. We'll go through the first one. So the comprehensive care management is where the health action plan is involved. That's where the care team members get together and work towards enumerating or listing all of the different issues that the member is having problems with, different conditions, their socioeconomic status, how they're doing with getting to follow-up appointments, the different medications that they take. And then basically it has all those things listed, what we're doing for them, and is it working? And then if it's not, then we need to change what we're doing for them. That's the kind of premise of it. Some of these right here that you'll see in bullet form are some of the things that are included on somebody's health action plan. And like I said, it's basically a head-to-toe assessment of everything that's going on with the member to try to get them the best care they possibly can. We have the health action plan implementation that's done by the care coordinator. The CBCMEs actually, some people had said, oh, well, he already has case management. Well, that means that they have some sort of plan, some sort of, basically a health action plan to get them where they need to go. Well, with that document that they've already done a lot of work with, they can easily adapt that to fit the health action plan compliance and make it so that they could work with it in the Health Homes program. So if these folks are already working with case managers, they could still get going. Care coordination is the next service, and that's where the care coordinator comes in. They're the primary key point of contact for members and the rest of the Health Homes program care team. They help with getting people connected to different services. They work with the other care team members to ensure that people are adhering to treatment modalities and managing their medications appropriately. They're the MVP for sure. They can actually accompany members to critical appointments as needed. That say that there's an appointment that, maybe there's a lot of, literally doctors speak in different languages, Latin and Greek, right? And so maybe there's some terms that they don't understand. Well, that care coordinator actually go with them and explain things in layman's terms to ensure that they understand. And they also monitor everything with referrals and ensuring that they're getting where they need to go. Health promotion, actually teaching and coaching members on how to support themselves independently. If that's not something that they're capable of, it's just helping them understand and helping their family members and those around them understand, so that they can just really do the best evidence-based practice to make sure that they're managing their care appropriately. And then we have comprehensive transitional care. So if somebody's being transferred between different care settings, we need to make sure that they're doing that easily and safely, and collaborating, communicating, coordinating with all the providers in the different care settings, from hospital to home or to clinic or wherever. And so ensuring that they have that summary of care record, after visit summary, as some people say, AVS, to ensure that everything's lining up and working appropriately. They plan sometimes weeks in ahead the follow-up appointments and making sure that they're getting to the proper rehab facilities and educated about how they're supposed to take their medications and how basically just covering everything they possibly can for the member. Member and family supports is the one that I was mentioning before that I thought was really important. It actually makes it so that the members of their family and any member of their support system can really help in a substantive way in ensuring that, okay, well, hey, like Chris, remember the doctor said that you're supposed to take this medication, you know, at night instead of in the morning, or vice versa. Just basically an extra layer of support for them. And then they can also accompany members to clinical appointments as well to make sure that they're getting all the information and service that they need. And then we have our referrals to community and social services, the last one. They actively identify community and social services that are needed within the community, and they'll actually get them referred to those social services, help people maintain and obtain housing, and then routinely following up with members and organizations to ensure that needed services are obtained. Some common barriers, we're talking about the Medi-Cal population, so there are quite a few financial barriers, maybe inconsistent or unreliable transportation, inadequate housing. These are some of the barriers that you'll see. I'm going so fast, I'm sorry. Their housing navigation services is for folks who are experiencing chronic homelessness. And you know, like I said, they're a paraprofessional that works the system, not works the system, you know, I mean, like they actually work with the system to ensure that the member smoothly navigates it. And then we have our informational sharing. It's encouraged that providers use technology like electronic health records to safely and quickly send information back and forth. That's where the health action plan is shared between team members. And then managed care plans are required to report data on enrollment, utilization costs, and healthcare quality measures established by CMS. Here is the implementation schedule. You'll see that, like I said, phase 1 and phase 2, there's kind of a 6-month stagger, and that's for folks with serious mental illness, and we're part of phase 2. You can see that these are the 12 counties that are going forward with this program. So unfortunately, Humboldt is not on that list, but there are quite a few all up and down, basically from Sacramento down to Imperial, down south. All right, and here's a little bit of enrollment update data as of September 30th. Numbers have increased significantly since then, but they are not public as of now, but these are what we were looking at around September 30th of last year. But again, the numbers have grown since. We have a member story here, but I don't think we have enough time to go through with it. To suffice it to say, the member had all of these issues that needed work, and he was able to get everything he needed as a result of his care coordinator and the rest of his care team. It was really, really awesome. And we're getting more and more success stories every day coming in from managed care plans about this. So we're really excited. It's really helping people. Here's a 1-800 number. It's called Healthcare Options. What they'll do is get you in touch with the appropriate managed care plan. And you know, there's even numbers on their website for different languages. Everything from Arabic to Vietnamese is represented there. All you got to do is look up healthcare options, and it should pop up, and you'll see it all down the right column. But that's 1-800-430-4263 is the English version. And then my last slide, right on time, right? A few extra resources. You see that bit.ly link right there, that URL right here. This is a truncated URL that will take you to the Health Homes website at DHCS. As you can see, it pops up there, dhcs.ca.gov. You'll see the Health Homes program information there. They have a whole bunch of extra information, program overview, outreach and education materials, as well as training and program resources. Now, I have my email here, chris@aurrerahealth.com. Please reach out to me if there are any questions, or you could reach out to Sonia as well if you don't want to reach out directly to me. And I'll try to answer everything and all that you send my way. I just want to make sure that, you know, people get this information. Again, you know, I say this at every single training I do, and I know it's one, but you know, if you know of any other organizations or folks that could utilize this information, please reach out to me, and I'll see if I can't get a training just like this for them. That this is a service we do on behalf of the state for free. So thank you so much for your time, and I apologize for the very quick last bit of this, but thank you so much for your time and for your attention. And I really hope that it helps people. Thank you.
Thank you so much, Chris. It's like it's like an intensive case management to try to help people who are struggling to reduce their hospitalizations and really connect them with a lot of extra services. So that's just a great program. And I'm glad that we were able to share it today. Thank you all for being here with lots of great questions. And please do share it out to others that you know might be interested. And thank you, Kadada, for typing in all the counties. So again, thank you, Chris, and thank you all for being here. Have a great day, stay safe, and we will see you again soon. All right, take care, bye-bye.
Thank you, everybody.
Thank you.